Welcome to the Westin MCAT podcast with your hosts, Eric Olson
and Jayden Garcia.
All right, welcome back to the Westin MCAT podcast. I am Eric. I'm filling in for Ahmed today as the host. So feels like a lot of pressure, Jayden. I don't know. I'm not feeling great about it, but we'll figure it out.
I'm glad you're taking that role, Eric. I like to.
How's residency treating you? How have you been holding up with things?
Residency's good, man. It's been an up and down roller coaster, I think. Some months are harder than others. This month was particularly light, which is nice. I think
Great
it's
news.
nice when those pop up. We've just been working on airway management. That's something in our field we do quite a bit in the hospital, has some disaster airways that we have to learn to manage. And it's led to a really nice schedule this week and just been intubating left and right. And
Awesome.
I think on Friday I'm due back in the surgical ICU. So
good stuff. Well, I'm starting in the ICU on Friday too. That's crazy.
We compare notes. I'm not looking forward to it. I'm not sure if you are.
It's not the preferred location for a future dermatologist, but it is what it is. Are you intubating in the ORs or in the ICU, or where have you been?
It's been mainly in the operating room. We've been in the ICU too for kind of more urgent things, but we have been placed all over the children's hospital, in the adult hospital, in the cardiovascular center, just trying to get a lot of repetitions.
Yeah, absolutely.
So
Very cool.
What about you, man?
It's good. I'm on a dermatology rotation this month. So it's been fun. I've seen some, the guy I'm working with is Mo's surgeon. So I've seen some surgeries. He does some cosmetics and aesthetic sort of things as well. So that's been interesting. And then he has a couple of PAs that work for him as well that do some more medical dermatology, which I don't know. Maybe I'm looking at it the wrong way. I haven't really talked to any current residents about how to go about things, but in my head, like, I need to learn medical dermatology and then I can kind of work on these other branches like the cosmetics and the surgery. But again, I don't know. It's all kind of new. You don't learn a lot of dermatology in medical school.
Right.
So it's a lot to take on, but the hours are good and certainly much better than yours, I imagine. So I can't complain.
Has it reinforced your desire to stay in dermatology, finally getting an opportunity to practice what you're supposed to be doing for the rest of your life?
Yeah, finally. Yeah, it's been 8 months leading up to finally doing some dermatology. Yeah, it's great. I mean, it's fun. It's definitely fun. Some cases are more interesting than others, but there's a lot to think about and puzzles to solve and things. So it's been fun. Well, it's good that you talk about intubating. Actually, we have an episode for you all today about action potentials and the neuromuscular junction and kind of movement and the nervous system. And some of what we'll talk about is kind of like induction drugs for intubations and paralytics and things like that act at the neuromuscular junction. So it's actually pretty relevant what you've been doing lately to what we'll be talking about today. So Jayden, I don't know if you want to start us off and tell us a little bit about kind of the pathway of a thought or an impulse to movement and kind of what the anatomy looks like moving towards from brain to muscle cells.
Yeah. And Eric, we, together with our experience coaching the MCAT for quite a few years now, I think we both recognize this is a fairly large topic that can be tested in many different ways, especially along this pathway from brain to muscle. There's a lot that takes place. And I think it's important for students to understand the big picture, and then we can kind of fill in some of the more intricate details that often get tested. And so big picture, if you think about it, in the brain, in the frontal lobe, right in the posterior frontal lobe, there's the primary motor cortex. And that is really where this whole process of movement originates. And so an action potential, which we'll get into a little bit more throughout the episode, is initiated in that cortex. and moves all the way from cortex down to and through the spinal cord, which will eventually lead to a muscle. And at that muscle, the interface between nerve and muscle is what we call the neuromuscular junction. And so essentially from brain until muscle, there's energy that's essentially moving as potential energy through those nerves to hopefully lead to a release of a transmitter, which we call acetylcholine in skeletal muscle, that can hopefully talk to the muscle, and through a host of steps, which will cover, tell that muscle, it's time to move. And so it's pretty incredible, just the thought of moving a muscle and starting that process, that we can do that. And there's certainly a lot of disease processes along the way that will prevent, said movement from happening. And I think it's important because, the MCAT loves to bring some random article, which may be really deep in medicine, that they're not expecting a pre-medical student to really know the medicine of, or maybe even super basic sciencey. But you have to understand the big picture so that you can extrapolate what you can from that pretty dense article, because they will go back to those things they do expect you to know. And big picture, it's, what I just explained.
Yeah.
And so we can kind of get into more detail as you see. Mm-hmm.
Yeah. Sorry for interrupting. I just wanted to say and kind of build off of the idea of what the MCAT will do. We talk about kind of making connections across disciplines and trying to see, again, how is the MCAT going to test you? You're not going to see and foresee and predict all the ways that the MCAT is going to test you. You can't, predict the passages that they'll give you, but you can make connections that will help you to kind of think through some of the problems that they'll give you. And so I'm just thinking about what you said, Jayden, and, you started with the brain. You said, in the I don't know, you said the posterior most frontal cortex. And I'm thinking about the neuroanatomy, right? There's a central sulcus. And so that's like the prefrontal gyrus, or the precentral gyrus, I think, that is the motor cortex. And right behind it sits the sensory cortex and the parietal lobe, right? Thinking about where those are kind of in relation to each other, thinking about the homunculus and, what areas of our body get more sensation, like the lips and the tongue and the genitals and the fingers and the hands and things like that. And then as you think about, the path that those impulses take, we'll talk a little bit about action potential, but an action potential itself, as it propagates down the neuron, is electrical energy, right? Because you have this imbalance in the ions that are moving in one direction or another, kind of inside and out of the neuron body. And that causes this difference in electrical potential. And as that moves down towards the neuromuscular junction, it kind of changes from this electrical energy to a chemical potential energy. And so, again, this is like a physics topic as we talk about conservation of energy and how these things kind of mix together, and how energy is conserved, but can be kind of transferred from one form to another. And these are all things that the MCAT might pull and say, well, ask a question about exactly what we're talking about conservation of energy, or about different energy types, things like that. So something to be think about. As far as the action potential itself goes, I did just want to touch briefly, because I think this is all super high yield stuff to me, and maybe it's because I'm a biologist at heart, and my major is in biology. And one of the things I love about dermatology is there's a lot of cell bio, and a lot of pathology that you can see in the skin is part of what makes it interesting to me. But because I love biology, I think something that's also really important is understanding the action potential and what it looks like and how it works. And so when we talk about action potential, this is, again, the way that a nerve is kind of propagating its signals down to other nerves and to muscles to make you move and to make you think and to make you feel things. The action potential, I wish we don't have a whiteboard here, but it would be helpful to look at a visual of an action potential that has, three main phases. It has a kind of a resting potential, which is about -70 millivolts, and that's kind of where it sits at rest. there's a depolarization phase where it moves from this -70 up towards 0 and it goes into the positives. I think it gets to about, I want to say it gets to like plus 40 or 50 millivolts, although I think that's maybe less important. Then it goes through a repolarization phase where it comes back down towards its initial resting voltage. And then there's a hyperpolarization phase where it goes kind of under that -70, which is also called kind of a refractory period. And that's another thing that can be tested as far as action potentials go. Each of these phases of the action potential corresponds to movement of a different ion. And again, we're getting a little bit into the weeds here. There's a lot we could talk about, but I bring this up only because to me, this is an area that the MCAT likes to test. They like to talk about ion movement and these kind of nitty-gritty details as far as action potential is concerned. And so part of what causes the resting potential of a neuron of that -70 is the sodium-potassium pump. The sodium-potassium pump uses an ATP hydrolysis. It uses some of that energy of an ATP to push sodium out into the extracellular environment and bring potassium into the cell, into the intracellular environment. And so in any given neuron, you have a lot of sodium outside of the neuron and a lot of potassium inside. And that's, again, created by that sodium-potassium pump, and that's what causes a neuron to have that -70 resting potential. Now, when you have an action potential propagating down a neuron, there are sodium channels that will open up and let sodium rush into the cell. And that's, this difference of concentrations, that there's a lot of sodium outside of the cell. When those channels open up, then sodium will rush into the cell, and that's what causes depolarization as the electrical balance of the cell will go into the positives. Now, once it gets up to the top of its action potential curve, the sodium channels will start to close and the potassium channels will open. And because there's a lot of potassium inside the cell, once those channels open, the potassium will leave the cell, and that will bring that resting potential, or the potential of the cell, back down towards -70. And so, again, I have probably seen, half a dozen practice questions where it's pointing to a point on an action potential curve and saying, what ion is causing this move? What ion is causing the action potential to move in this particular direction? And you have to be thinking about what's happening with sodium, what's happening with potassium, what's happening with the sodium-potassium pump, and where are the ions flowing, and how is that changing this electrical balance? And so having a good visual of that and really understanding that flow and those couple different steps can be really helpful for some of those sorts of questions.
Yeah, and I think, excuse me, the MCAT highlights a very important principle of clinical medicine, which is, in order to know disease states or to know the abnormal, you really have to have down the normal. What is an action potential supposed to look like, which is what you drew out for us in our minds here, Eric. And clinical medicine is all about that. And the MCAT can take something normal, like the action potential you just finished discussing, and give us some scenario of like a mouse that has some abnormal pump or some abnormal channel for some of these ions, and then ask us what will happen next. And so I think that was a reasonable time to talk about that, because if students don't really understand all these intricacies of the action potential, what a normal curve is supposed to look like, when they see this on the MCAT, which it's rarely ever the normal, they've deranged something and asked you as the test taker to respond to, what would the effect be if we tinkered with something.
Yeah.
And I think that's important too, because in clinical medicine, most of the drugs that they will be asked to know as medical students here in the next year are going to impact action potentials, not just in the brain, but also in the heart. Mm-hmm. Those are two major organ systems we emphasize a lot in medical training. And so many of our drugs influence some of these same channels that you talked about. When you give somebody lidocaine versus amiodarone, there's so many things that impact the potential. And the MCAT, I believe, will still test you on the difference between, a nervous cell or a neuron and a cardiac action potential, because they're quite different.
Yeah.
And so I think the homework for our students listening is to go and look at the cardiac myocyte and compare that to what you just drew out, Eric. I think that's an important point that often gets tested. Some of those thresholds are different in cardiac cells. The point at which sodium rushes in versus potassium leaves is a little different. And so I kind of challenge our listeners here to go and look at a neuron action potential and compare it with a cardiac myocyte.
Yeah, I think, ideally we might even have to have a whole other discussion, another episode about cardiac and smooth muscle too, action potential, because they are different. And part of it has to do with these channels. Did you ever take, Jayden and I had the same undergrad. Did you take physiology from Dr. Porter, who was the dean of the College of Life Sciences?
No, I heard good things though.
He was a good teacher, and I think he had taught at a medical school. I want to say it was St. Louis University. And I remember he used to say, "Oh, I'm going to teach you so that you're a board certified endocrinologist." Is what he always used to say. He loved the endocrine system, but I remember he would talk about the funny channel, and there's a channel in the heart that's called the funny channel, and I don't recall exactly what it. I think it's always open, and so it kind of allows the heart to have that self-beating, like pacemaker capacity, that it's always kind of depolarizing on its own and reaching that threshold of depolarization. And so that's why you have a regular heartbeat. I may be wrong on that. I don't know. I'll have to verify. But he was an interesting teacher. I remember I liked looking at his pictures. But I'm just thinking, Jayden, as well, I don't know if you ever listen to like podcasts and things. I think some of our listeners probably are watching on YouTube, but I think many are probably just listening without the video component. And when I was getting ready for the step 1 and step 2, which are board exams that you take in medical school, I used to listen to this guy who recorded these audios, like, I don't know, 20 plus years ago. Golyon's Pathology.
Oh, yeah.
Guy.
Oh,
and
absolutely.
He would tell these stories, and the audios would always be like, "Look at this slide. What do you see?" And people would describe what they were seeing. And so part of me in listening to those audios, and I imagine what some of our listeners are doing now, they're thinking like, well, I really needed a visual for this. And this is fine, but it would have been helpful to have a visual. And, I don't disagree. But the beauty of listening to those was that, I could do it anywhere. I was listening to it in the gym sometimes, or I would go for a walk, or, I was driving to work, or whatever the case may be. And a lot of the stories that he told and things like that, and just the repetition of listening to him talk about different pathophysiology really stuck with me. And so some of those things came in handy on some of those board exams. And, I would just say that even if you're not watching right now, even if, we're maybe not drawing something out, it's helpful to be listening and just to have your brain kind of turned on and thinking about action potentials. Even if you're not getting everything that we're saying, just taking in kind of one fact or two facts here and there, those things can be really helpful. I don't know. Did you ever do anything like that, Jayden?
Oh, definitely. Yeah. And, as a surgeon, something my mentors always say is you don't know the anatomy until you can draw it out. Because I think it's very easy to talk about, where a structure is in the head and neck, in my region specifically, but having this mental image that we're trying to portray and having our listeners kind of mirror that in their own mind, I think is a really good first step. And I think to take it to the next level is them being able to write it down on a piece of paper, not necessarily from memory, but really thinking through some of those channels that you talked about, and why is it that there's this major upward deflection as soon as sodium rushes into the cell, because it's going positive. So the MCAT, I think when we were in the trenches teaching students for so long this test, we realized that it doesn't have to be as memorization heavy as a lot of students try and make it. Yeah. And you really, if you focus more on the core principles of science and trying to understand why things happen the way they do instead of just that they do, I think, will stick a lot more. That's why we're so removed from these things, but we can still at least regurgitate what we think is fairly accurate, and it's because I think we had a deeper understanding when we were students. And so I think that's a plug for that principle of preparing for the MCAT.
Yeah, no question. Well, let's talk a little bit about We've talked about kind of the basics of the action potential and where it comes from the brain and where it goes. And in the case of, motor impulses, right? When you have a motor impulse, it's coming from the brain and going to the skeletal muscles. When you have a sensory impulse, it's coming from, one of the sensory organs, like a Pacinian corpuscle or a Meissner's corpuscle or something like that, and moving upwards towards the brain.
Mm-hmm.
So two kind of different systems there. But as we talk about motor impulses, we've talked about this and kind of touched on how the MCAT might test some of these principles. Again, I would just emphasize before we move on that the MCAT loves to kind of cross-cover systems and ideas. And so when you think about a principle like an action potential, you have to think about everything that it touches. You have to think about muscles, you have to think about nerves, you have to think about ions, you have to think about, the brain. Ultimately, like you might have to think about psychological principles because you're talking about cognition and things like that. And so the more that you kind of make these associations and things, the easier it will be when the MCAT asks you to do something like that. I want to talk about some of these like clinical scenarios that we want to bring up for you guys. But before I do, let's talk about the neuromuscular junction, Jayden, really quick. Do you want to just give a basic, and I'll maybe fill in any other gaps that get left about the neuromuscular junction?
And we kind of ended this story, or at least paused it at this nerve or neuron that has led to an action potential down to what we call the axon terminal. Mm-hmm. And so this is really the end of the nervous system as we start to approach the muscular system. And as that electrical energy gets converted to chemical energy, at that axon terminal, there are vesicles with acetylcholine inside of them. And there are proteins, a host of them, which will become very relevant when we discuss Botox in this, that help move that vesicle to the end of the neuron to just spout it out into what we call this synaptic cleft, mm-hmm. which is this space in between the nerve and the muscle. And you can imagine now there's a ton of acetylcholine sitting in this space, and there are receptors on the muscle, which we call the motor end plate. Vocabulary is really important for this topic.
Yeah.
Because they may just give you some of these terms: motor end plate, synaptic cleft, axon terminal, etc. So there's all this acetylcholine that is just bathing the synaptic cleft. And on the motor end plate are receptors for acetylcholine. And it's really important because for the rest of your medical career, you're going to have to be thinking of what kind of receptor. And in this case, in skeletal muscle, we call it the nicotinic acetylcholine receptor. I'm going to just put a plug in that they love to confuse you in the differences between skeletal, smooth, and even into parasympathetic and sympathetic responses, because each of these may use acetylcholine receptors, but specifically in skeletal muscle, we're talking about nicotinic. And so acetylcholine will bind to that nicotinic receptor. I believe it's sodium. Remind me, Eric, is sodium or calcium? Something will rush into the cell to cause a rush or an increase in that action potential or into that voltage going more.
Yeah, so it's sodium.
Sodium. And that will unlock a whole set of voltage-gated sodium channels. And again, we're going to see a similar phenomenon as in the neuron, where electrical or potential energy is going to spread across the muscle cell down into what we call the T-tubules.
Mm-hmm.
And this will trigger a channel called the dihydropyridine channel with a receptor, which will change the configuration of the ryanodine protein and receptor. And this will then unlock a ton of calcium that will rush out from the sarcoplasmic reticulum, mm-hmm. which is where all of our calcium is stored. And at this point, calcium can do its job in the muscle cell. It's going to find troponin. When it binds to troponin is a protein that sits down in the sarcomere. And essentially, until calcium is bound, it and tropomyosin are blocking myosin from binding to actin. And so when calcium combines to that troponin, it changes the configuration of these enzymes, which will move out of the way to allow actin and myosin to have an interface. And when that happens, myosin, using ATP, which is a whole other kind of lecture, will use potential energy of ATP and hydrolysis to move along the actin chain, causing these two proteins to essentially come closer together. And that leads to contraction. What do you want to add there, Eric?
No, I think that was beautiful. As you talk about it, I think more and more like, man, we could spend an hour talking just about actin and myosin and that cycle of hydrolysis of ATP and like the cocking and uncocking of the myosin as it pulls actin along. We could spend an hour just talking about the neuromuscular junction, and we could spend an hour talking about an action potential and the different types of action potentials and the different channels. And so I would just reiterate that, make these connections and then go back and draw these things out and think about them and really ingrain them into your mind, because there's a lot to cover here and we're not covering all of it, or we are, but just shallowly. And so, but no, I think that was great. I will just share this because I think it was a great visual for me, also from Dr. Porter, I believe. These all my pearl physiology
proceeds from.
He doesn't even know. But I think that part with the dihydropurity receptor and the ryanodine receptor can get a little bit confusing. I don't know if it's super high yield for the MCAT, but just I think it can come up, and for the sake of covering it, I agree with you. Once acetylcholine binds onto that muscle cell, or those I guess acetylcholine receptors in the muscle cell membrane, and I'll add a term which is the sarcolemma, being the membrane of the muscle cell, right, and the neurolemma being the membrane of the neuron. Then you get these action potentials that propagate with influx of sodium into the muscle cell. Again, just as you said, the action potential will propagate down a T tubule. It will change the configuration of the dihydropurine receptor, just as you said. And the way that Dr. Porter explained it was that it would, he said it was like connected by like a spring to the ryanodine receptor. And the ryanodine receptor is like a trapdoor on the sarcoplasmic reticulum. And so you would change the dihydropurine receptor would pull on the trapdoor of the ryanodine receptor, and it would let all that calcium out into the cell. And again, exactly what you said. That's basically the whole point of this whole motor impulse coming from the cortex down the motor neurons and to the muscle cells, is that you get this release of calcium into the cell. Again, it's intracellular, right? It's an intracellular release of calcium, and then that calcium can do its job in allowing the actin and myosin to form the cross bridges and contract skeletal muscle. So again, a lot of pieces, a lot of steps, all very important to understand. And I think it's worth another look. But let's jump into the neuromuscular junction, because that's where a lot of, as you said, a lot of the drugs that we use will work on the neuromuscular junction, and a lot of the drugs that we talk about in clinical medicine will have an effect here. Again, there are all these different steps, and so there are all these different ways that we can affect these sorts of processes. So Jayden, you were doing intubations this week. Why don't you tell us a little bit about some of the paralytic agents that we can use in intubation, if you don't mind, and how they work differently.
Yeah, I think this could be a totally fair passage, right, on the MCAT.
Absolutely. Not something that the MCAT would say as a standalone, like which one of these drugs acts this way, right? But they could give you a passage about succinylcholine and then ask you a follow-up question about some of the things we've talked about. No question.
And I think every test taker should assume when they're reading a passage, even if it seems quite foreign in the beginning, that you know something about this topic. You may not know some of these drugs I'm about to list off, but you do know how skeletal myocytes are stimulated to contract. And if you think about it, a patient who's undergoing intubation, so I'm sticking in my laryngoscope blade, I really need this patient to not move.
What? Just for everyone, because I would have known that 5 years ago. What is intubation?
Yeah, so intubation is essentially where we place a breathing tube through someone's vocal cords, which will place that tube inside the trachea. We can inflate a balloon at the end of the tube, and essentially we can give them air to breathe for them in certain scenarios. When somebody's undergoing an operation, usually their lungs are okay, but we need them to be still and we need them to not remember what's happening to them. And so we essentially take over their breathing. But before we can do that, we have to go through this process of intubation. And we essentially stick in their mouth a metal blade. It's not very sharp, but it helps us get a good visual of the vocal cords.
Kind of like a heavy tongue depressor, if you think about it. You use the tongue depressor and you bring their tongue down so you can see back into the throat. The laryngoscope is kind of curved like this, and so you can put it in there and kind of lift up so you have a better visual, right? Correct me if I'm wrong.
But no, that's perfect.
Yeah, go ahead.
We need a good visual of the vocal cords so we can put the tube through them. And to do that, you really need the patient to be paralyzed if you want to optimize that process, which can be a little scary to think about, that you're getting paralyzed before a surgery. But if all the muscles in the head and neck are super tense and tight because a big metal blade is in your mouth, you can imagine it makes it very difficult to place that tube. And so we use a few different neuromuscular blockers to paralyze the patient. And we kind of take advantage of this neuromuscular junction we've been talking about. So acetylcholine, we discussed, sits in that synaptic cleft, looking to come in contact with the nicotinic acetylcholine receptor. We can give a drug, which we often do if we're trying to quickly intubate somebody, maybe in an emergent setting in the ER or something like that. That's called succinylcholine. And what it does is it binds to that same receptor that acetylcholine is trying to bind to, and it just ends up sticking and hanging around on that receptor a lot longer than acetylcholine does. And initially, it actually causes muscles to contract the same way acetylcholine does. So when I push this medication, when I give somebody this medication, you see their entire body like almost seize for a second. We call that fasciculations. And that's because that action potential we discussed along the myocyte is being activated. But then the succinylcholine just sticks around. It just hangs on to the nicotinic acetylcholine receptor, preventing acetylcholine from binding further. And that leads to a flaccid paralysis after that, meaning they don't move.
Well,
and they're essentially paralyzed. What's that?
That's what we want.
That's what we want. We've achieved our desired effect if that happens. And the good news is that medicine only lasts for about 15 minutes before the patient will start to move again. So it's really good if you just want to use it quickly and turn it right off. So we call that a depolarizing neuromuscular blockade, because that initial fasciculations where the patient actually undergoes contractions.
So that's the depolarization, which is causing the same cascade that we were just talking about and causing contraction, and then ultimately it makes it so that there could be no more acetylcholine binding to those receptors. Is that right?
Yeah, it kind of.
These are things I don't know a lot about because I'm not intubating people all day.
It's a really helpful drug. Similarly, I think the other medicine that has gained much more popularity in the last decade is rocuronium and its cousin drugs. Rocuronium works very similarly. It gets into the synaptic cleft. It binds to the nicotinic acetylcholine receptor, just like succinylcholine does, but it, for whatever reason, doesn't activate the action potential, and in fact, kind of shuts everything down from the get-go. This medicine lasts a lot longer. This is really good in certain cases where you just don't want the patient moving at all. If you're working in the brain, you don't want them moving around. If you're like us trying to work on the facial nerve, it's a bad idea because I actually need to see that the facial nerve can move. So it's not a good choice in some of my surgeries that we do. So yeah, we manipulate this same physiology all the time to have a successful surgery, which many of our listeners have had successful surgeries. And I'd say those are the two most common drugs we use. And they both are what I would consider competitive antagonists of the acetylcholine receptor, right? That's another MCAT principle they could test you on. They can now test your knowledge on Michaelis-Menten or competitive versus uncompetitive inhibitors and how they work. So there's a lot of tie-ins to this subject, and that's why Eric and I, decided to talk about it today, because the clinical medicine, but also the MCAT ties are numerous.
Yeah, it's a beautiful point, and I can foresee in someone's MCAT in the future there's going to be a Lineweaver-Burke plot, and it's going to be like, here's this drug, and what kind of inhibition is it, or what kind of antagonist is it, and you're going to be like, oh, I wish I had studied Lineweaver-Burke plots more.
If somebody doesn't get a Lineweaver-Burke plot on the MCAT, please write me a message, because I don't think that happens.
It
You
is
should expect
inevitable.
at least one question, probably a lot more.
It's annoying though, because it's so it's such a weird sort of graph and question type. And so you have to spend all this time figuring it out just to probably do like one, maybe two questions on a Lineweaver-Burke plot, but you have to do it. You just have to.
You have to.
Yeah. So very interesting stuff. There are different paralytic agents that we use, but these are some of the common ones that we use today. Couple other things that we thought were interesting to share with you all. And Jayden, I kind of want to talk about Botox, but I feel like you should talk about it. You probably actually know something about Botox. I'll put you on myasthenia gravis.
Yeah, give it your shot. I'm no expert on Botox, but Eric and I both use it in our fields, and in fact, many specialists in various.
It's true. There's Botox in dentistry. There's Botox in oral maxillofacial surgery. There's Botox in neurology. It's all over the place now. It's increasing in its usages. I will say that this month that I've been at a private dermatology practice, I've seen a good deal of Botox done, and I have thought many a time that I needed to get. I don't know. There's not a lot of men coming in doing Botox, but I feel like if anyone needed it, like there's a lot of lines there, and I got this like. I'm recruiting pretty heavily into the frown. So I don't know. Anyway, that's neither here nor there. Let's talk about myasthenia gravis really quickly. So myasthenia gravis is a relatively common neurological disorder. And the way that we usually see it presenting is with someone who can't quite keep their eyes open. They're like having trouble with these fine motor movements and having trouble with fatigue in their muscles. And the pathophysiology behind it is pretty interesting. What happens is that we have the production of antibodies that attack or bind to the acetylcholine receptors on the postsynaptic membrane. And because of that, it kind of prevents binding of acetylcholine to those receptors. And when you don't have as much acetylcholine binding to those receptors, it's harder to get an action potential propagated. And when you can't get an action potential, then you can't get muscle contraction, and it's harder to keep those muscles working like they're supposed to, and you get fatigued easily. And so if you think about, you use your muscles all the time to keep your eyes open. And so when these muscles in your eyelids are not working quite as well, then you have trouble keeping your eyes open, and you end up a lot of times having what we call ptosis, which is, can't keep your eyes open. So there's some interesting things about myasthenia gravis. It's associated with thymomas, or a tumor of the thymus gland, which is, the gland that helps in T cell development that sits right over the heart. And so a lot of times these patients are ultimately treated with thymoma resection. They take out the thymus, because in an adult, it's not really used for much. It's helpful in babies and in toddlers as we kind of ramp up our immune system and as we develop our T cells. But in an adult, it's not helpful. And so it can be removed in an individual with myasthenia gravis. And a lot of times that will resolve their disease. So it's pretty interesting. But one other kind of interesting way that I don't know, it's kind of like a factoid that we learn in medical school, I guess I should say. There are two ways to diagnose myasthenia gravis that are commonly used. And Jayden, you can correct me if you have any additional thoughts, but one is a blood test that just tests for acetylcholine receptor antibodies. was kind of a newer wave test because we didn't always have the capability for testing for antibodies and things like that. And so that's one of the things that we'll use today that hasn't been used for quite so long of a time. Before that, we would use a drug called edrophonium. And edrophonium is a drug that is an acetylcholinesterase inhibitor. And this is another huge topic. Like, again, I feel like we could talk for 30 minutes on acetylcholinesterase and acetylcholinesterase inhibitors. If you think about what the name acetylcholinesterase implies, it's an esterase, meaning it's going to cleave something, right? And what is it cleaving? Acetylcholine. And so when acetylcholinesterase is working, it's getting rid of acetylcholine and preventing it from being inside of the synaptic cleft. I love what Jayden said. The synaptic cleft is bathed in acetylcholine. I love that. I love that visual.
Like that
so when you have acetylcholinesterase that's working, it's draining the tub. It's getting that acetylcholine out of the synaptic cleft. When we use an acetylcholinesterase inhibitor like edrophonium, it again inhibits acetylcholinesterase, and in so doing, it adds to the acetylcholine or allows the acetylcholine in the synaptic cleft to stick around for longer. And that kind of counteracts the action of these antibodies in myasthenia gravis that are covering up the binding sites for acetylcholine on those acetylcholine receptors. And so when we use edrophonium, there's more acetylcholine. It's easier to have an action potential propagating down the muscle membrane, and it's easier to have muscle contraction. And so in a patient with myasthenia gravis, if you have a patient with ptosis and they're having a hard time keeping their eyes open and you give them edrophonium, then they'll be able to open their eyes. It reverses the pathology because there's more acetylcholine that's available to propagate those action potentials and to allow muscle contraction to take place. And so it's like a diagnostic test that we'll use in order to determine, what's going on with this patient, why they have ptosis. A positive edrophonium test would indicate that individual has myasthenia gravis. And then again, there are different drug options down the line of treatments. And then as well, you can consider surgery and thymoma resection in these sorts of patients. Yeah. Anything to add?
I just want to take a moment to encourage these pre-medical students in this path. I know it's so easy to think that these topics are useless for you to learn about, that you're going to do something else with your life that don't relate to clinical medicine. But hopefully over the last 20 minutes, as we've discussed multiple applications of just one topic, you see that the courses you've taken, this test you're about to take, is necessary for you to build a foundation. Myasthenia gravis is life-threatening. I just took care of a patient who was in critical condition last month when I was working in the neuro ICU. Had to intubate this patient because she was in complete respiratory failure. It starts with the eyes, but quickly spreads to the lungs in these crises that they have, and they cannot move their muscles of their lungs and therefore go into respiratory failure.
Yeah, the diaphragm.
Their diaphragm's involved, their chest wall can't move. All these things that we use when we're trying to breathe, they have no ability to do. And our knowledge of these core science principles and physiology is what drives treating them. You can't just intubate them and leave them sedated, right? There's a host of therapies we use that work to enhance this synaptic cleft problem. And so I just wanted to point that out, that these things are important that you're learning. They will help you actually save lives someday. And so I hope that gives some motivation to keep going.
Beautiful sentiment. And on that note, perhaps we can talk about something that's maybe less life-threatening in Botox. Although, like you said, I mean, there are lots of applications. Botox is used for TMJ now. It's used for chronic headaches, and there are other indications under study right now. So I think it is a wonderful drug. But tell us about it, Jayden.
Yeah, Botox is amazing, friends. It's not just a cosmetic drug, which it certainly can improve the self-esteem of many people around the country and the world. But essentially, going back to this axon terminal, we talked about vesicles that are full of acetylcholine waiting to just be released into the synaptic cleft. which will eventually lead to muscle contraction. Will enter the axon terminal and prevent the proteins that allow that vesicle to move to the end of the axon terminal and be released from doing that job. And so essentially these acetylcholine vesicles can never be released, and that leads to paralysis because the muscle never sees the acetylcholine. They're stuck inside the neuron terminal. Which, if a patient has botulism, this is the toxin that causes patients to have a flaccid paralysis. And so it's a horrible thing if an infant or an adult gets botulism because they become paralyzed from the neck down all over their body. But we have exploited this opportunity and use it in drug form to stop certain muscles from moving. And so Eric was kind of showing us with his face, people have furrows or they have wrinkles and all these things, which is kind of a contraction of a muscle. But if you can inject it in the muscle, it will get into the nerve terminal and prevent those muscles from moving. And so all of a sudden wrinkles go away. Or I think something near and dear to my heart is I take care of a lot of patients with facial paralysis. So sometimes patients can have what's called Bell's palsy, which is just a virus that leads to complete hemifacial paralysis. One side of your face, just one day, you just can't move. And some patients don't ever get movement back in their face. And the nerve starts to freak out, not knowing what to do, the nerve that moves your face, that is. And so it starts attaching to random muscles. And so these patients will come into my clinic and they blink because that's the muscle they're trying to move. The little bit of blinking that they can do leads to like a huge spasm on the other side of their face. This is called synkinesis, or abnormal movement.
You start your video, Jayden. Sorry.
Oh yeah, sorry.
You were stuck.
My voice?
I can hear you, but you're stuck on video. But go ahead.
Anyways, synkinesis is a real problem, and it's really these axon terminals that find their way to random muscles as they try and learn to regrow. But we use Botox to inject into these muscles that are inappropriately contracting. No patient likes to blink and then have their ear move or their other side of their lip move. I mean, it's very distressing for them. And so that's kind of an application in my world. Eric, I'll throw it back over to you as far as Botox, and any thoughts on that?
Yeah, I don't have too much to add. I think it's, we don't have to get into it too much, but just as far as interest goes, it is kind of an interesting story of, I think there was an outbreak, or there was a point of time in which a bunch of people died from botulism. As you said, it's the same toxin. And so there were some researchers who were trying to figure out what happened, and they isolated these toxins and said, I think there are like 8 different botulism toxins or something like that, A through G, I think, or A through H, I'm not sure. And each one of the toxins kind of has a different effect. And botulinum toxin A is the one that's the most studied. But they saw in their initial studies that it was causing muscular paralysis. And it was initially used in children with strabismus. And this is, again, something you'll learn about at medical school. But it's basically when one of the muscles controlling the movement in your eye pulls too much. And so you have one eye that's looking forward and one eye is a little bit off because one muscle is kind of pulling it one way. And so it was initially used, this botulinum toxin, and injected into these muscles that were pulling too hard to prevent that extra pulling and to allow eyes to kind of move in the same direction and be, as kind of a non-surgical adjunct treatment, because generally speaking, the treatment for strabismus is surgery. And so that's how it was initially used. And in one of these patients that they had injected into the periocular muscles, they saw that it was with the glabella, when you make this frown face, that like these muscles weren't working as well and these lines disappeared. And so that's when, and it was just like in the 70s or the 80s, and they said, oh, maybe we can use this for cosmetic purposes. And that's when they started injecting into these different areas. And so it is kind of an interesting story of, a terrible disease in botulism that has been kind of co-opted for other uses. And so it's interesting, but again, something that I've seen probably every day for the last month is injection of Botox, and understanding, the mechanism and how those things work is certainly helpful when discussing with patients, and helpful as a clinician determining, how best to utilize these treatments. So the pathophysiology is important. These principles are important. They do matter, not just for the MCAT, certainly for the MCAT, but for clinical medicine moving forward in your lives. So with that, I think we'll leave you unless you have anything else to add, Jayden. And
Nope, that's
exciting
it.
to all of you.
Take care, guys.